We'll talk today about the menopause and hormonal replacement therapy. It will be into two parts, each about half an hour. So we'll start with part one of it by the contents of what we are going to talk about. We're going to talk about definitions, the declining oocyte pool, the physiology of the menopause, the hormonal changes in the menopause, the menopausal symptoms or the symptoms of the menopause, the special concern for menopausal women, and the management of the menopause. We start by the definition. The menopause comes from two Greek words. Menos means the month, and pausis means cessation. So it is the last menstrual period. It is a permanent cessation of menses, dated by the last menstrual period, followed by 12 months of amenorrhea. So after the last or the final menstrual period, we have to have a period of about 12 months or 1 year to make the diagnosis. The normal age for the menopause ranges between 42 to 57 years, with an average age of 51 years. The physiological changes which result in the final menstrual period can start 10 years prior to this. That's to say, in the last part of the reproductive life of the woman, the changes in the hormones of the menopause could start as early as 10 years before the final stoppage of the menses. So the diagnosis is made retrospectively after a minimum of 1 year's amenorrhea, 1 year after the final menstrual period. Can also be induced, the menopause, by ovarectomy or iatrogenic ablation of ovarian function. The transition from reproductive to post-reproductive life divided into several stages, with the final menstrual period serving as an anchor for that. So progressive period for the final menstrual period before it occurs. So what happens in the ovarian pool, the follicles in the female ovary? Usually a newborn female infant has over 1 million oocytes already present in her ovary at birth, unlike the male, where the testes keep producing sperms after birth, or even after sometimes after birth, and they continue for life, while the oocyte cohort shrinks throughout life, such that there are only few thousand oocytes left as a woman enters her 40s, and a few or none in the postmenopause. So all the pool is there, declining or going into atresia every cycle, till by the age of 40 or at the time of the menopause, there may be none. The depletion of the oocytes eventually leads to the cessation of the menstruation. Two landmarks in the ovarian failure process. The first, marked decline in fertility with no dysfunction. That's to say, after the age of 40, for example, the fertility declines. The menses could go normal, but the fertility declines. Then after that, subsequently, the cycle changes become noticeable as the follicular phase shortens, and the luteal phase dysfunction occurs. So initially, declined fertility with normal menses. Then eventually, the menses become abnormal due to the follicular phase shortening and luteal phase dysfunctions. So the menopausal transition traditionally terms the perimenopause or the climacteric, is the transition period for regular menstruation until menopause. This may last for 5 years or more and is highly variable in duration. This is the perimenopause, characterized by the menstrual cycle changes, includes variable cycle length, skipped periods, and increasingly longer intervals of amenorrhea. The transition is associated with cessation of ovulation, no ovulation, marked decline in estradiol production, and a modest decline in androgen production. And as we know, estrogen and testosterone are produced by the ovary, as well as progesterone, of course. So this is the change that takes place. So the diagnosis is clinical. We don't depend very much on the hormonal diagnosis. It's clinical to say amenorrhea 12 months after the final menstrual period. And obviously, we go into the age, as you have said, the age is about 43 or 45 to 52 or something like that. So the early menopause, then we categorize the menopause into the early menopause. It occurs after the age of 40, but before the age of 45. This is, we call it early menopause. With the early menopause, sometimes we got a menopause which is due to pathological conditions, what we call primary ovarian insufficiency. It entails, or it means, cessation of the menstrual periods due to failure of the ovaries prior to the age of 40 years old. It's also called premature ovarian failure, premature ovarian insufficiency, or premature menopause. So all primary ovarian insufficiency. It affects about 1% of women 40 years or younger. It is occurring before the age of 40. If it's between 40 and 45, we call it early menopause. Less than 40, it is primary ovarian insufficiency, and we diagnose it by 3 parameters: an age to be less than 40 years. There should be an amenorrhea over 4 months, and there should be an FSH 40 million international units per annum. The third group of menopause is medical menopause. Refers to temporary or permanent amenorrhea resulting from various medical treatments, such as ovarian suppression with gonadotropin releasing hormone agonists, GnRH analogs or agonists. And these, as we have said earlier, we use them sometimes in the treatment of large fibroids before or after, or before surgery, or without surgery. And once we use them, some of the ladies could go into medical menopause. Other possible causes of the medical menopause: chemotherapy-induced amenorrhea, oncologic radiation therapy, and the fourth category is the surgical menopause. So it could be a normal menopause, could be early menopause, it could be primary ovarian insufficiency or failure, it could be medical menopause or surgical menopause. This occurs, the surgical menopause, after a bilateral ovarectomy in a premenopausal woman and results in an abrupt estrogen withdrawal. Often it is associated with more severe symptoms than patient experiencing the natural or the normal menopause. So these are the categories of the menopause. We go into physiology of the menopause in general. As we have said about the ovarian pool, the oocytes undergo atresia throughout a woman's life, with follicular quantity and quality undergoing decline approximately 20 to 25 years after menarche. So after this age, the follicles decline either in their quantity or their quality or function. This follicular decline results in loss of ovarian sensitivity to GnRH or to gonadotrophin stimulation. GnRH stimulates the pituitary to produce gonadotrophin, which stimulates and acts on the ovary. So during the perimenopausal period, follicular dysfunction can lead to variable menstrual cycle length. The follicular phase is usually shortened due to the decreased number of functional follicles. As we have mentioned, the follicles are reduced in number and quality, functioning-wise. So reduction of the functioning ovaries, follicles or oocytes in functional quantity will lead to shortening of the follicular phase. The early menopause transition is typified by increased level of FSH, leading to overall higher estrogen levels. Then follicular depletion, as the follicular depletion continues, there is decreased inhibin production produced by the follicles that leads to continued increased FSH. Follicular depletion also leads to recurrent anovulation and subsequent increase in FSH and LH. This is the picture how it looks, starting with the ovarian dysfunction here. Initially, hypothalamus acts on the pituitary, producing FSH and LH. They act on the ovary in a normal situation. When there is going into the menopause, then estrogen is reduced, inhibin is being reduced because there is no gonadal stimulation, no stimulation. So here, leading to depletion of the reduction in inhibin and estradiol, leading to an increased production of FSH, LH, norepinephrine, dopamine, prostaglandins, leading to the vasomotor symptoms, here the hot flushes, and the insomnia and depression. While here, the absence or the failure of the hormones of estrogen from the ovary leads to bone changes, leading to osteoporosis, cardiovascular system leading to atherosclerosis, and atrophy in either the genital tract or the breast. We'll see it in a minute. So here are the physiological changes interacting with each other. In the perimenopausal period, there is an increased pulsatility in GnRH production, leading to increased production of FSH and LH, acting on the pituitary, leading to slight decline of estrogen and inhibin, moderate fall in progesterone, progressive decline in testosterone. This is in the perimenopausal period. In early postmenopause, there is progressive decrease in GnRH pulsatility. In the perimenopause, decrease in pulsatility, leading to further increase in FSH and LH production, leading to decline in estrogen, inhibin, and progesterone, and progressive decline in testosterone. The hormonal changes in the menopause, in late postmenopausal and later years, there is a reduction in the levels of GnRH with progressive decline in FSH and LH. This leads to sustained very low levels of estrogen, undetectable levels of progesterone and inhibin, are sustained low levels of testosterone that may increase after 70 years of age. So low levels of estrogen, undetectable levels of progesterone and inhibin, and sustained low level of testosterone. Low level. So this is in the late postmenopausal system. The symptoms of the menopause are quite a number. We mention them and then we regroup them for easy memorization. The most common symptoms are hot flushes and headaches, night sweats, urinary symptoms and the vaginal dryness. So you look at the hot flushes in the face and headaches with night sweats in the vagina and urinary symptoms. There is vaginal dryness. The mood will be low, feeling anxious, anxiety, sometimes sad and depressed. Insomnia, forgetfulness, Alzheimer's disease may be common in ladies later on. Then other symptoms in the joint and skeletal changes, accelerate bone loss leading to osteoporosis, heart disease, and stroke. Loss of interest in having sex. So quite a number of symptoms that occur with the menopause. We group them into the following category. Menstrual cycle disturbances, vasomotor symptoms, genitourinary symptoms or syndrome, cognitive changes, depression, and anxiety. So we're trying to remember them. If you put them in these 5 groups, then you will see what happens in each group. So the menstrual cycle disturbances, irregular bleeding in both duration and timing, including skipped cycles and anovulatory cycles. So the cycles become irregular, both in timing, continue for so many days, and in the duration, with some periods of amenorrhea and with some anovulatory cycle. That's due to increasing fluctuation in FSH and estradiol and shortening of the follicular phase from 14 days to 10 days. Sometimes in these menstrual disturbances, we may need to think about malignant conditions or neoplasm, and we have to reevaluate or to look into other possible causes of the disturbance of the periods in the perimenstrual period or early on, or in early menopause. Conditions which we need to evaluate and look into includes episodes of heavy bleeding. If the bleeding occurs more often than every 21 days, if it lasts longer than 8 days, if it occurs after a 6-month interval of amenorrhea. If in these 4 situations, then we suspect neoplasm, then we have to evaluate the endometrium, and the evaluation could be by ultrasound, by endometrial biopsy, possible D&C, dilatation and curettage with hysteroscopy. The vasomotor symptoms. We talked about the menstrual symptoms, the vasomotor symptoms. 75% of women in the menopausal age experience vasomotor symptoms, such as hot flushes and night sweats. Symptoms begin an average of 2 years before the final menstrual period. We have noted that it has been shown or noted that 8% of women who have hot flushes endure them for longer than 1 year without any complaint. 50% may endure them for longer than 5 years. So some of the patients may endure these vasomotor symptoms and they don't come with it. The vasomotor symptoms characterized by sudden reddening of the skin over the head, neck and chest, accompanied by a feeling of intense body heat, palpitations and anxiety, sleep disturbance, irritability, memory loss, tiredness, poor concentration. And they conclude with profuse perspiration. The pathophysiology of these vasomotor symptoms in the menopause due to vasomotor instability. This is secondary to dysfunction of the thermoregulatory nucleus, which is responsible for maintaining body temperature within a set range known as the thermoregulatory zone. The risk factor for these changes are surgical menopause, and we have said the symptoms are usually marked and more severe. Up to 90% of women who have surgical menopause, that's the removal of both ovaries, will have vasomotor symptoms, or early menopause, or low estradiol levels, smoking, and possibly low body mass index. These are risk factors for patients to present with vasomotor symptoms. The third group of symptoms is the genitourinary syndrome of the menopause, or symptoms. Pathophysiology, the vagina, the urethra, and the bladder trigone have a high estrogen receptor concentration. Vagina, urethra, bladder trigone, high level of estrogen receptor concentrations normally. So in the menopause, estrogen will be low. This leads to absence of effect on these organs, and it will lead to urogenital atrophy. Affecting the vulva loses most of its collagen, adipose tissue, and water-retaining ability, and becomes flattened and thin. Older women may have shrinkage and fusion of the labia with narrowing of the vaginal introitus. Sebaceous glands remain intact, but secretions decrease, leading to vaginal dryness. So vaginal dryness will occur, shortening and narrowing of the vagina will occur, and this will affect the walls, become thin, loosely elastic, and become pale in color, and dyspareunia will be the end result of it. So the woman will present with dyspareunia related to the low level of estrogen, of not acting on the vagina and the vulva. The genitourinary syndrome continues. It occurs because embryologically the urethra and trigone of the bladder are both dried from the lower two-thirds of the vagina, and their associated atrophic changes give rise to irritative bladder symptoms and prolapse. So embryologically, they are coming from the same source, having the high level of estrogen receptors in bladder, trigone, and the urethra, like the vagina. So the effect of the low level of estrogen will be on the vagina as well as on the urethra and trigone. So the estrogen deficiency is associated with urethral syndrome, which is characterized by recurrent episodes of urinary frequency and urgency with dyspareunia or dysuria. There is an increase in pH of the normally mildly acidic environment within the vagina, and the incidence of urinary tract infection is increased, as are episodes of minor cystitis that can accompany sexual activity. So increased infections, genital tract infection, increased urinary tract infections, minor cystitis affecting the sexual ability. Many women complain of loss of sexual desire around the menopause, and the menopausal symptoms of vaginal atrophy may lead to tiredness and discomfort, and there is also a reduced response to sexual stimuli, and women may experience more difficulty reaching orgasm, as well as their male partners may also have reduced interest and may have difficulty in getting or maintaining an erection. That could be a contributing factor to the female problems of the sexual desire, sexual libido, and sexual activity. And this is part of the problems of the menopause. The cognitive changes, we said the incidence of subjective cognitive changes, complaints during the menopausal transition range from about 30 to up to 90%. Estrogen has a role in supporting the memory and prefrontal cortex functioning. Declines in estrogen during the menopausal transition are associated with reduced cognitive functioning. There is an accelerated deterioration of cognitive function once the menopause begins. So reduced initially, then it accelerates and deteriorates the cognitive functions. And we'll see what we mean by the cognitive functions. And this is, we find that Alzheimer's disease is almost 3 times more common in women than in men in the menopause. It has been found in cultured cells and animal models that estrogen has a protective effect on the neurons. So depression and anxiety comes due to the decline of estrogen occurring around the time of the menopause, associated with mood changes. One of them is depression, the other is anxiety or poor sleep maintenance. Depression, almost 2 to 4 times higher. Risk factor to depression, if there was a prior depressive episode, lady during her reproductive life, she had a depressive episode, most likely she will get it in the menopause. History of stressful events during childhood, prior premenstrual syndrome, prior postpartum depression, and lengthier menopausal transition. Anxiety, the menopausal transition is associated with new onset anxiety in women without a history of anxiety. The risk factor, a history of high premenopausal anxiety. Poor sleep maintenance occurs in almost 40 to 60% of menopausal women. We have special concerns in the menopause. Immediate menopausal effect, the concerns here include insomnia, anxiety, irritability, memory loss, tiredness, poor concentration. This is the immediate menopausal effects, and the woman may complain of that. In the intermediate menopausal effects, estrogen deficiency leads to rapid loss of collagen, which contributes to the generalizable atrophy that occurs after the menopause. In the genital tract, manifested by dyspareunia and vaginal bleeding from the fragile atrophic vaginal skin. This is the intermediate menopause concern or effect. Late menopause, then we are concerned about bone, cardiovascular disease, central nervous system, where estrogen promotes the neuronal growth and neurotransmission and may improve the cerebral perfusion and cognition in the woman. Osteoporosis due decreased bone mass and bone microarchitectural deterioration with the resulting increase of risk of skeletal fractures. The most common fractures we see are in the lumbar vertebra, the wrist, the distal part of the radius, and the neck of the femur or the hip. Estrogen deficiency causes an imbalance of skeletal remodeling with increase in resorption greater than bone formation. Estrogen binds to receptors on osteoclast, break down the bone, and inhibit their activity. So the increasing bone mineral density has to be tested, and it has to be evaluated regularly or routinely for women at the age of 65 years and above. The bone mineral density. Factors affecting the bone mineral density leading to its being low, that's to say, in other words, leading to more fractures, are low body weight, current smokers, family history of osteoporosis, previous fragility fractures, chronic corticosteroid use, alcoholism, use of anti-epileptic drugs, low calcium and vitamin D intake, endocrine disorders such as hyperparathyroidism, hyperthyroidism, hypogonadism, Cushing syndrome, premature menopause, rheumatoid arthritis, malabsorption, inflammatory bowel disease, chronic liver disease. So the list is quite big that affects the bone mineral density and could lead to fractures, especially in the menopause. We have to look for these, and accordingly, we may need to assess the bone mineral density frequently or give the treatment for that. Another special concern for menopausal women is the cardiovascular disease. Women are protected against cardiovascular before the menopause, after which the incidence increases, reaching a similar frequency to men by the age of 70. Before then, women have less incidence or prevalence of cardiovascular disease. In the menopause, they start to have an increased rise of the cardiovascular problems due to deficiency of estrogen, and they may be similar to men after the age of 70. The coronary artery disease is the leading cause of death among postmenopausal women. Protective effect in the premenopausal women is mediated by an increase in the high density lipoprotein. So in premenopausal period, the estrogen has a protective effect. And this is mediated through an increase in high density lipoprotein with a decrease in low density lipoprotein. Nitric acid oxide mediated vasodilation leading to increased myocardial blood flow, an antioxidant effect on the endothelial cells, a direct effect on the aorta, decreasing atheroma. So these are effects of estrogen protecting in the cardiovascular system. So we stop here. Thank you very much. This is the end of part 1, and we'll go to part 2.